We have our recording going now, so thanks everyone for joining in for our next installment of the ACVNU Journal Club. Tonight we have Dr. Metzere Bierlein to share with us the benign ureteral obstruction in cats, the discussion on medical management, and I'm sure it's going to veer into some other methods of management as well too. Really excited for everyone to join. As always, we want this to be interactive and discussion rather than just a presentation by Metzere, although we are certainly psyched for that. So please keep yourself muted unless you have a comment or a question, but we certainly encourage you to speak up when you do, or feel free to use the chat. I'll try to monitor that as well too. And we hope to make this a great discussion on management of cats with nephroureteral obstruction. So with that, Metzere, why don't you take it away?
All right. Well, thanks for the introduction. I chose this topic because I remember being very excited when it came out the last year of my residency. And now as we've just done urology and nephrology the past 2 years at my practice, I've gone to see that it's a lot less black and white than I used to think. And it's just made me come up with more questions. So I'm excited to see what the group has to say. And in order to facilitate the interactions, I did add some polls to the slides. So I'll walk you through how to respond to the polls, and we'll see what everybody thinks. All right. So the background of the author's paper is fairly straightforward. We know that benign ureteral obstruction is a common phenomenon in cats, secondary to uroliths, of which 98% are calcium oxalates, but strictures and pyonephrosis as well. There are certainly other causes, such as circumcaval ureters and other non-benign obstructive causes, but the authors did not focus on those in this paper. It was just benign causes. Treatment options we know are medical management, various surgical options as well, including ureterotomy, neuroureterocystotomy, the subcutaneous bypass device, and ureteral stents. And now some of our peers in Minnesota are looking at burst wave lithotripsy as well. But there's a question mark next to that because we don't have any publications as of yet. Before this paper came out, there was only one veterinary study published in JAVMA in 2005 that looked at the success rate of medical management, and it was quite low at 18 to 13% in 52 cats. One of the other reasons that I chose this paper is we always like a good debate, and this one sparked some nice letters to the editors. There's also a reply from Dr. DiBartola himself regarding what is the gold standard of veterinary medicine, but for the sake of time, I didn't include that in this discussion. But the authors did spark some controversy by stating that the placement of a subcutaneous ureteral bypass device is the standard of care, and they cited high hospital discharge rates of 94%, as well as median survival times of around 820 days. And so this slide kind of just focuses on that letter and the response to that letter as well. The letters written by Dr. Aronson and others oppose the viewpoint that the sub is the gold standard by citing a height rate of bacteriuria post-sub, the long-term financial commitment for sub-flushing. And the point that I found particularly interesting was the argument for continued pain with the remnant ureteral stones. I have had other surgeons cite that as well, but I found myself agreeing more with Dr. Dunn's response in that I don't clinically feel that I see notable pain on my patients on rechecks of their subs as well. And I think there's some debate regarding the pathophysiology of what exactly causes the pain associated with ureteral obstruction. They also stated that the sub carries good outcome in the hands of many surgeons, regardless of their specialized training. Similar rates of bacteriuria in cats with CKD alone, regardless of sub, and that many of these patients still have the need for CKD monitoring, regardless of whether the sub is actually flushed or not. So I enjoyed that letter. I don't know what anybody else thought, if they had any agreements or disagreements, but I thought it was a nice controversy with really good arguments on both sides.
I thought it was interesting that the same articles were essentially used by both sides. You can pick and look at the data in a way that you're like, yeah, the article says exactly what I'm agreeing with. And then the other side would also say, yes, this article says exactly what I'm trying to say. So yeah, I think it probably comes down to the fact that we don't have big data in our patients to make it more of, I guess, less gray and more black and white. Even then, it's still going to be difficult, but it's a lot of argument of how you look at these 6 patients and how they were managed versus those 2 or 4 or 15 patients. So I just thought that was interesting and probably leads us to take away with, well, that's why we need to have this conversation and additional conversations from here.
Yes, I agree with that. So then this is one of the polls. You can either join by the web, entering this website. You can technically text by sending this to the number 37607, or you can scan the QR code. And I basically want to poll the group just to get a random kind of assessment of what you consider the standard of care in your practice for feeling ureteral obstruction if medical management has failed. So far, everybody's saying the sub, so we all seem to be on similar page, but I'll give it another minute, see if there are any other responses. Okay, we have 1 ureteral stent. It looks like Dr. Dunn has raised her hand. Would you care to speak, Dr. Dunn?
Yeah, just a quick question, because we talk about benign ureteral obstruction. There's also strictures, and I don't think you'd want to be using burst wave lithotripsy on a stricture. So I guess just kind of more lifts and
yeah.
that.
Yeah, that's a great point to point out. Yes.
And likewise, you wouldn't want to be using a stent on a stricture. So,
although we can look back, and I think it was Mike Zaid's paper that showed pretty positive results with cats that had stents placed for strictures, and who knows, maybe you do want to try birth wave lithotripsy for the strictures with the response rate that was seen in this manuscript. And I say that like half jokingly, but I'm sure we'll get to that part, but that was very interesting to me. Yeah. So we'll see.
All right, so moving on, it looks like most of us said the sub, but of course, everything is a case-by-case basis with all of these cats. So, and I know that's obviously a shortcoming of any polls, but I figured it would make things a little bit more interactive and interesting. So the study objectives were to describe the clinical pathologic findings and the outcomes of medical management in cats with benign ureteral obstruction. Their criteria were that medical management was performed for at least 72 hours compared to cats who underwent the sub procedure or were euthanized. And secondary aims were to determine if there were any pre-treatment features, whether that was clinicopathological or perhaps the actual medical treatments themselves that could predict success or failure of medical management. So this was a retrospective study from the University of Montreal, and the diagnosis of obstruction was based on a combination of several criteria, such as renal pelvis dilation, This was the majority, I believe, actually all of the cats. These findings were on ultrasound. It could have diverticular dilation, ureteral dilatation, or some combination of these. And there is usually visualization of an obstructive intraluminal lesion, with the exception of a stricture. They diagnosed a suspected stricture when on ultrasound an abrupt decrease in the ureteral luminal diameter was observed without evidence of a cause for the obstruction. And there were 3 groups of cats: those in medical management alone, the group that was euthanized, or those that underwent an interventional procedure, which at this facility was subrastent only. So I was curious to pull the group as to what is the most common imaging modality you use in your practice to diagnose a suspected ureteral obstruction in cats. Looks like so far we have ultrasound as the most common, but ureteropielogram is a second, not a very close second, but second option. Looks like nobody is really using abdominal CT. So I'd say that's about what I expected, similar to what we would use in our practice as well. So then when we had one change. Okay. Okay, looks like we're still pretty similar, with 89% saying ultrasound, 11% saying ureteropielogram. So then as a follow-up question, again, I realize this isn't black or white, but I was curious what you would do if ultrasound failed to diagnose the cause of ureteral obstruction. What would you use as your second choice? Would you then consider CT, ureteropielogram, or your surgeons wouldn't care and they would take it to surgery and determine it intra-op? Okay, now it looks like we have the majority saying ureteropielogram, with fewer saying CT, and 6%, 5% saying surgical explore. I realize that can be a little bit of a difficult question because some of you may argue that your surgeon will do the ureteropielogram in the OR, which would be all of our preferences. But for those whose surgeons don't always trust you as much as you would like, I was curious if some of you had to do the ureteropielogram yourself.
Yes. Based upon the frustration in your voice, do you find that you have challenges with surgeons believing your assessment that your patient is obstructed?
So I found that it's extremely practice dependent, as I'm sure everyone does. I would say that surprisingly, during my residency, I think I had a harder time convincing the surgeons, and we would often be forced to do medical management for longer, probably than most of us would want. And then they would finally take it, versus at this kind of more private practice, I think that Dr. Ross did an excellent job before I ever stepped foot in getting the surgeons to trust her. So I think that they are a lot more likely to take a case based on the radiologist's assessment and ours that we suspect obstruction, whether or not the radiologist can definitively visualize an obstruction. But I mean, to be quite frank, I don't know that I truly became good at diagnosing ureteral obstruction regardless of what a radiologist did or did not tell me until probably the very end of my residency, you know, going into my fellowship. I don't feel like it was something I was taught in vet school. It was always just, well, the radiologist will tell you if there's an obstruction, or you'll see the obstruction, but I think it took me a long time to learn it's not that easy. And sometimes we have to diagnose these ourselves, regardless of what the radiologist or surgeon will tell us.
Yeah, and I think that they're probably learning how to diagnose it better too. You know, the classic description of a hydronephrotic kidney, anybody can diagnose from across the room.
Yeah.
Hopefully we're dealing with less imagers, I'll say, because it certainly could be internists or radiologists that are doing it that will be reluctant to diagnose obstruction if they fail to see the obstructive lesion. But that is a huge problem that we'll still see, where we'll get referrals for dialysis, and I'm sure many people here have had the same situation, that instead of dialyzing the cat, you place a sub in it because the ultrasound that they performed, the referring practice performed, is diagnostic. They just wouldn't call it because they failed to see a stone or something like that.
Mm-hmm.
So I think our radiologists are probably getting a bit better, and but I had a similar experience regarding surgeons being eager or accepting a diagnosis unless radiology called it. They would be reluctant. And Nob, who's on the rounds today, I mean, his paper looking at pyelograms and the outcome and safety of percutaneous pyelography was essentially fueled by the fact that we had to do so many of them to come to a diagnosis, because we didn't have radiologists that were convinced, and then the surgeons wouldn't go to surgery without radiologists signing off on it. So that's that we had that paper.
Yeah, and it looks like we have a lot of people raising their hands and chat. So I'll try and read through the chat, but Dr. Ross, go ahead.
No, I just wanted to see everybody's impression. Do you think it's been easier to convince the surgeons to cut because most of the time now people are placing subs versus a stent? I mean, I think back to the days, which is before most of you were born, but before stents, when we were talking about doing ureterotomies, that was a hard sell because you had to show them exactly where to go. Then stents came along and it became, I don't want to say easier, it certainly wasn't easier, but it didn't matter as much exactly where the obstruction was, as so long as you could prove to them it was obstructed. And then subs came along and it became even a little bit more of an easier sell. That wasn't English, but you know what I mean, in that they were bypassing the ureter, so they didn't have to mess with it. So I don't know. I think it just has gotten, as things are evolving, I think it may be a little bit easier to convince them to go. I mean, you just got to start them early and train them. It's like a puppy. But don't get me wrong. I love surgeons. They're some of my best friends, but you do need to train them.
Yeah, I guess I'd be also curious to know, because I've never been at a practice where the surgeons are still primarily relying on ureterotomy or near ureterocystotomy, if that's still the case. Like at Penn, you know, do their surgeons have to know exactly where the lesion is before they will cut it, or are they still prone to take the cat to surgery and do the ureteropyelogram themselves without needing that information? I don't know. I don't know if anybody knows on the call. Yeah.
I guess I have a tiny bit of experience based on the study that I published, because when I started my residency here at Tufts, it was really painful to see that they were placing a sub, but then absolutely chasing the stone. And so they wanted to do a ureterotomy as well to remove the stone. And so what I didn't realize is, first of all, how long it takes to actually remove the stones. And we had our ophthalmologist, who is also a surgeon, so he was really working with the loop and everything, and so all the fancy material to be able to do that as best as possible. But I guess what I never realized is, as soon as they open the ureter, probably because of a change of pressure, even if it is a stone and you open exactly where the stone is, the stone is going to shift. And so that's really sort of a nightmare of, yes, you open at the right spot where the stone was, but then the stone can move and you may still be here for hours trying to milk out this stone that has moved, or closing your first spot and reopening at another one. So it's really not as easy as opening where the stone is and removing it. And of course, that's just talking about one stone. We don't even talk about when there's multiple ones.
That's a great point. I never thought about that because I'm not a surgeon. So I appreciate you pointing that out and giving me more to think about. That definitely is interesting.
But I think our fumbling in those earlier days made it easier for us to train our surgeons when Manny came along and said, hey, this really is crazy, guys. So now basically we just say it's obstructed. We're coming in with you, and the surgeons just, assist us, and we work as a team. So it's kind of interesting hearing how many are having the surgeons do most of the work.
Mm-hmm. Yeah, I mean, I've definitely found that to be practice dependent, and I guess just how much training people received as internists or criticalists, learning to place subs with their surgeons or not. And I'll be the first to admit, like I had a lot of practice managing them post-op, and I think most surgeons are happy to send them back to us because they don't want to be the ones managing the CKD or flushing the subs. But I've never really had much experience learning to place those. And honestly, like I like interventional, but the thought of a sub by myself, even with the surgeon, kind of scares me. And that's where I'm like, I don't know, maybe that's where the surgeon needs to step in and do that. But I know that's just personal preference. But I am curious how many people go in with the surgeon in their practice. It's not something that I've commonly encountered, but yeah. Yes, go ahead. Dr. Adams, would you like to go first?
Sure. I go in and do the nephrostomy tube placement and then assist the surgeons from there.
Mm-hmm. Yeah, and it sounds like that's not uncommon in other people that we have with Dr. Dunn. And yes, and then versus Dr. Foster says most people, it sounds like his surgeons do it themselves. And I would say that's also what I'm used to at the practices I've been to. And then Dr. Buddy says that they are also in charge of the intraop pyelogram and nephrostomy tube. So it looks to be, we actually might have more people on the meeting that are assisting their surgeons, at least in this group that we have today. And then, yes, Dennis agrees that the surgeons do it all there. But I do see your point, Dr. Dunn. It is quite nice to know when we're the ones ultrasounding it, whether it was completely in the pelvis, did they put it in the proximal ureter. Those details would be nice, and our surgeons don't always note that unless we go and directly talk to them. Yeah. So yeah, I mean, I think that's a great discussion and something that definitely there's a lot to be learned of. And I definitely hope one day to be able to join a practice where it is more common for the nephrologists, internists, criticalists, you know, us in the ACVNU college to be able to go in with our surgeons. So that's a great discussion point. So moving on through Dr. Dunn's paper, for each ureter in the medical management group, the outcome was retrospectively classified as a success, a partial success, or a failure. The success was resolution of the obstruction or resolution of pelvic and ureteral dilatation, or both. Partial success was at least a 50% decrease in the renal pelvic diameter, but there was still persistence of the obstructive cause. And then failure was worsening of the renal pelvic diameter, or less than a 50% improvement. The failure group also included euthanasia or death from obstruction, or if a decision was made to proceed with an IR procedure after 72 hours. So for the results, there were 78 cats in the IR group and a similar number in the medical management group, 72 cats, and then slightly fewer, 50 cats in the euthanasia group. There was no significant difference in the cat's age, sex, weight, or breed between all three groups. This particular table is only looking at the IR versus the euthanasia groups. And you can see that although not significant, there were slightly more cats in the euthanasia group with bilateral obstructions. The significant differences were that in the euthanasia group, 49% had unknown cause of their obstruction, and this was significantly higher than both the IR and the medical management group. And then not shown here, but in the text of the paper, they cite that the medically managed group had a significantly higher percentage of pyonephrosis as the cause for their obstruction. And then this table is looking at the medical management group at the top, euthanasia group in the middle, and IR below. And they are comparing various clinicopathologic data on admission. It is small text, but you can hopefully see that the stars represent significant differences. So of the hematocrits, while it wasn't a large difference, in general, the IR group was slightly more anemic at 30%. The creatinine was significantly higher in the euthanasia group at 10.7 versus 5.9 in the IR group and 4 in the medical managed group. And although not significant, in general, the BUN trends were similar, with highest in the euthanasia group. The phosphorus as well was higher in the euthanasia group at 12.8 compared to 9 for the IR and 5.7 for the medical group. Potassium was not significant between three groups, and not completely surprisingly, the pH was significantly lower in the euthanasia group at 7.17, and the bicarbonate as well reflected this with 11.9 in the euthanasia group. So I know this is a lot of numbers on one slide, but I did my best to try and condense it. In this section, they looked at the medical management, specifically what fluids or drugs were used in these groups. So, and I guess I just had a question for Dr. Dunn because I wasn't sure that I could determine it from the study, but I was curious if you had a rough idea of which of these patients were solely managed on outpatient versus those that were originally hospitalized and then discharged and continued management as an outpatient.
Isabel, Dr. Mahendal, I think is on the call. Did you want to answer, Isabel, if you remember the?
Yeah, I think it was about 20% of patients that were just outpatients versus hospitalized. So basically, like when they were hospitalized, they were receiving IV fluids. I don't think any patients were only receiving subcutaneous fluids.
So then, just out of curiosity, and I realize maybe it's a case-by-case basis, but are you generally always recommending hospitalization and inpatient management for these cats, even if they come to you as, say, an appointment or a referral, or is it really just case-by-case basis?
I guess I can answer that. So in general, I mean, I think it depends on the degree of azotemia. The majority were azotemic. Every now and then you get that non-azotemic fortuitous finding, or it comes in for vomiting or something, or some abdominal pain that we're not really sure if it's related or not, and we find obstruction. But the majority of cats, by the time we get an ultrasound by a radiologist, often they come in through ICE, emergency. They're often hospitalized for 24 hours or 36, 48 hours. By the time we get a diagnosis, get results back, and they get transferred to our service. So I'd say the majority of these had some fluids upon arrival and were hospitalized. And so we continued the fluids and as much as possible tried to at least keep them hospitalized a couple of days and see if there's an initial response to therapy, especially in the very sick azotemic patients. To see, and our goal, as I think you mentioned, for us, it's to relieve the obstruction as quickly as possible. And on our hands, in our institution, what works best for these cats is a sub. And so these were it's definitely biased, and I'm sure you'll come up, when you critique the article, there's a lot of bias in these, in the medically managed, because they were all owners that refused interventional treatment. And so for varying reasons, a lot of times it was financial. And so we tried to keep them hospitalized, but some refused hospitalization and they were discharged. But I'd say a lot of hospitalization decisions were made based on financial reasons and owner, wanting to bring the animals home. There's so much variability in how long they were hospitalized. But to answer your question, yes, we try to keep them in hospital and give them fluids and dilate them and see if we can help them through. And especially the pyonephrosis, we want to try to keep them on fluids and see if we could flush the pus out. But it's kind of a case-by-case basis.
Okay. Yeah, thanks. That helps with the interpretation. So the 82% of cats received IV fluids. Like she said, probably all inpatients for a median of 96 hours. 32% then received sub-Q fluids post-discharge for a median of 14 days. 86, so a large majority, received prazosin for a median of 11 days, and about a third received corticosteroids. At this facility, it was always in conjunction with prazosin, so never as a lone therapy, and a very low percentage, about 3%, received amitriptyline. Not surprisingly, the majority, about 2/3, received analgesics, of which buprenorphine was the most common, followed by gabapentin and remifentanil. And then specifically just in hospitalized patients, about a third received furosemide, most commonly as a bolus, versus about a quarter received it as a CRI. And the authors did note that about half of these patients were fluid overloaded or oliguric, and about 12.5% received mannitol. So then this is another poll. Again, I realize that's not a blanket statement, but I was just having you guys rank the following inpatient therapies from those you would be most to least likely to use. You cannot answer on text with this question because it's ranking, so you have to use the website or the QR code. Okay, so far I think we're probably getting close to most participants responding. Looks like we have a pretty close tie between the alpha antagonists and the pain medications, but I'll give it a minute or two for people to finish up. So I would say this is about what I was expecting, and it probably mirrors as well the decisions at our facility, with the alpha antagonist being the most common, followed by pain medications and steroids. I'm a little bit surprised of the furosemide over mannitol. Not that that's data-based at all, but for whatever reason, I guess I thought I was under the impression that maybe people would use mannitol a little bit more often than furosemide. And I realized that may be biased towards your population of how fluid overloaded they may or may not be, as well as hyperkalemic. But yeah, amitriptyline I've personally never used, so I suppose that doesn't totally surprise me. Is there, I guess, are there any factors that make you reach for amitriptyline over other medications? Because I don't know that I have in my mind a good case for when I would reach for that.
I just had to put it at the bottom of the list, so something had to go there.
Yeah.
I've never used it for that, certainly. I don't know if anyone else has used it for an acute obstruction.
I guess I'm a little bit curious to ask the crowd as well. Are you usually reaching for, let's say, like 1 or 2 medications at a time, like an alpha antagonist or pain medications, or do you find yourself usually reaching for 3 or 4 in your inpatients? Dr. Dunn says 3 or 4. Anybody else feel differently? Same with Dr. Foster and Dr. Adams. Okay, so it looks like top 3 are perhaps the most common routinely. Yes. Okay, so I think we're all fairly on the same page. Okay, so then the next slide is fairly similar, but it's just asking what you would reach for outpatient therapies. Looks pretty similar to our inpatients, but perhaps it looks like people are less likely to use subcutaneous fluids than, I would assume, IV fluids on the inpatient. I didn't list IV fluids as inpatient because I thought it would be too widespread. Dr. Dunn's made a good point that she doesn't usually use steroids with pyonephrosis, so I think that's a fair point. Yeah, so I wouldn't say necessarily any surprise here either. If I'm being honest, I guess I personally am always a little bit torn on the indication for subcutaneous fluids, depending, of course, on the cat's, how are they eating, drinking, or is there vomiting, etc. And I guess I've fallen away from using subcutaneous fluids to, quote unquote, flush the kidneys and try and move that stone. Just curious about everyone else's thoughts. Are you also not tending to use subcutaneous fluids very often if the cat is eating, drinking, or is that still something you consider doing?
I would say most animals that I've treated for an acute kidney injury do go home on subcutaneous fluids just to help them maintain their hydration during like a state of polyuria that would occur as they're continuing to recover from that injury.
Mhm. Yeah, it looks like the group has some differing opinions. Dr. Buddy would use it, but not with the obstruction, just to help with hydration. Dr. Foster probably wouldn't do it if they seem hydrated. So yeah, I mean, I understand it's definitely a case-by-case basis. And of course, maybe somewhat dependent as well on their degree of azotemia. But I guess for me, I have a hard time doing it if, for example, the cat's creatinine is like 2.5, 3, but they're eating, drinking normally and not losing large amounts of fluid through GI losses. And yes, I agree with Dr. Dunn that I would also as well prefer an E-tube or oral fluids. But usually I find the clients who may not pursue any sort of interventional therapy may also be the harder ones to convince of an E-tube, depending on finances, but yes. All right, so then only other question I had out of curiosity, because honestly, I've never known what the right or wrong answer is, but the authors say that on average, they use an alpha-2 antagonist for 11 days. That was just the median, of course, but do you generally prescribe this medication for a finite amount of time? Or do you use this medication until the obstruction has passed, potentially indefinitely in some cases? Okay, so far everybody has chosen B. We'll see if any more answers trickle in, but that's also generally how I've used the medication, never knowing if it eventually loses its efficacy. Do the alpha receptors ever just stop responding as well as they used to? Am I crazy and using it in a cat that's reobstructed 2 or 3 times for just keeping them on it for years? I never know. So that's why I wanted to get the group's opinion. But it seems like nobody, or at least people aren't admitting that they obviously will script it out for a certain amount of time and then discontinue it based on the results. So it's good to see that most of us are trying to use it until the obstruction is passed. But so we seem to be on the same page there. All right, so for the outcome, 30% of ureters were completely successfully managed medically, with the median time of about 16 days until that resolution. Not necessarily surprisingly, we saw higher success rates in the pyonephrosis and the strictures compared to the uroliths. So about 23% of uroliths were managed at around 14 days. The suspected strictures were around 22 days, and then the pyonephrosis took longer at 47 days. The partial success group was reported in 13%, with time to partial success of about 27 days. And then 57% of ureters failed medical management. And the risk factors that they looked at associated with outcomes is that cats that did respond successfully were significantly younger than those who failed. So 4 years versus 8 years. The blood work results, clinical pathologic findings such as the BUN, creatinine, phosphorus, potassium, hematocrit, and pH were not associated with outcome. and neither were the specific treatments that they looked at. Some of the biggest takeaway points were that the smaller uroliths, less than 1.44 and 1.05 millimeters, had a 50 and 60% probability of passage, respectively. And proximal uroliths were more prevalent in the failure group compared to the success rates, whereas distal uroliths were more prevalent in the success group than the failure rates. And the number of uroliths was also higher in the failure group, although this difference was not significant. So I would say that these outcomes were expected and not totally surprising, except for potentially the clinicopathologic findings, although similar to what we talk about in the Dialysis Academy, that's also been the case for animals undergoing dialysis. So I guess I should know better at this time than to necessarily always condemn a patient based on their degree of uremia. And then the long-term outcomes, they were able to look at patients and classified them by short-term and then midterm, which would be somewhere between 1 week and less than 3 months. Surprisingly, they had more outcomes in the midterm follow-up. I feel like generally we see more patients start to kind of drop out at that term, so that was interesting. And again, no huge significant differences, but in general, kind of looking at the trends, serum creatinine and BUN tended to be on the lower end for the success group compared to the failure group, whereas the hematocrit was fairly similar, but again, generally higher in the success group. Unfortunately, they didn't have a huge population to look at recurrence rates, but I was really happy that they took the time to try and give us some answers as to what percentage of patients may have this reoccurrence. And in their group, it was only 27 cats, and 6 of those had recurrence rate, which was about 22%. And the median time to that recurrence was about 84 days. So they didn't have quite enough data to have significant differences with the Kaplan-Meier curve. You can see here that on the right side, the partial success and success group generally had average longer survival probabilities, with the success having around 1,200 days, 518 days for the partial, and then 234 days for the failure. But again, there wasn't enough data at the long-term points to show significant differences. Okay, so for the discussion, their success rate was at least 30% with medical management after 72 hours, with again, the highest success rate in the pyelonephrosis and suspected stricture group. The authors do discuss that perhaps many of these suspected strictures may have been more of a ureteral spasm rather than stricture in a true sense. And on average, the strictures and stones took about 2 to 3 weeks for response to medical management, versus the pyelonephrosis was longer at around 1.5 months. And then 14% were dead within 1 month, which was significantly better than the prior study that reported a 30% rate. Again, 22% of cats had recurrence of obstruction, but that subpopulation of cats was too low for them to actually look at risk factors that might be associated with recurrence. So then I just wanted to pull the group and see if you have a medically managed patient that has recurrence of ureteral obstruction, would you be more inclined to pursue surgery, or on the flip side, would you be maybe more inclined to pursue medical management again since it worked the first time?
And I'm presuming it's the same side that was obstructed again.
Yeah.
If they obstructed the other side, then I probably would give it another shot if they responded well with medical management, but probably not if it was the same kidney.
Mhm. And of course, I'm sure it depends on if is it a stone or is it a stricture versus pyelonephrosis or something else. But it looks like most of us are still going for the standard of surgical IR procedure, which I think makes sense. So then just to finish up, the limitations, yes, the diagnostic testing wasn't standardized, so every patient didn't always have a culture or the exact same blood work testing as every other patient. The follow-up was difficult, as it always is for our cases, but all in all, their numbers weren't, again, that bad for the around less than 3 months time points, although, of course, we would like to know what truly happens to these cats within a year or longer. Probably the most disappointing thing, which is of course the hardest thing, is that the treatment protocols were not standardized. So again, what medications were chosen for what cat were very much up to the clinician's discretion. And pyelonephrosis was based on ultrasound findings. So technically not every cat had a positive culture, pyuria, or neutrophilia on CBC. And then outcome was based primarily on ultrasound findings alone because azotemia was not always a reliable marker, and that's been shown to be pretty consistent through several studies. So future studies, there's so many that I wish we could do. I would say going back to kind of the basic science, it would be very nice to have an isolated feline ureter model that could really allow us to examine contractions in response to different receptor stimulation. And that's how they've developed a lot of the protocols for human medicine based off of human ureters, but also porcine, rats, etc. And I believe there are a few studies in cats, but none that are as clinically directed as we might like to understand what drugs may or may not be useful in this medical management. In humans, they're starting to look at phosphodiesterase inhibitors, so that could be an interesting way to go. I don't know if anybody in the group has tried calcium channel blockers. I know it's kind of hit or miss with humans again, but it'd be interesting to see how our patients tolerate it. And then, of course, if we could have a multi-institutional study with standardized drug protocols, that might really give us the best information of determining what drugs, what combinations of those might improve medical management. So that's all I have. It was great getting everyone together to discuss this, but feel free to chime in with any questions or comments you have in your experience in these cases. I still have so many questions about what to do for what cases, but yeah, this has been helpful seeing how people manage theirs.
This paper was more similar to what I feel like makes sense, where distal ureteroliths were more likely to pass. But if you look back at the other paper, the Kyle's paper, now granted, I think they only had 7 cats that had successful medical management. So it was like 7 out of 52 or something like that. But they all actually had proximal ureteroliths. And, based upon that, which certainly they didn't look at risk factors or things, but it was just very odd that all of the cats that had shown, that had a response had proximal ureteroliths, which to me always just seems like you have a lot of road to travel there, little stone. That's no bigger than where you're at now. So you're probably going to run into more problems. But I imagine that maybe was coincidence and a small sample size, because I think the results of this are a lot more preferable, align with what I see. If there's one right at the UVJ, I'm hoping that if we shake the cat enough and get the owners to take it on a roller coaster or something, we can get it to pass with a higher chance of success than with a really proximal one.
Yes. Go ahead, Dr. Adams.
I wanted to reiterate that I'm very thankful for this paper, and thanks to the two authors that are on the call. I do want to add a comment that we do see patients that the azotemia improves and the renal pelvis gets smaller, not because the stone has passed, but because it has moved proximally enough to relieve the obstruction, because the ureter in the cat is parallel to the effects of gravity. So sometimes it moves back towards the kidney and unobstructs. And some of the cats in the Kyles et al. Paper improved, not because they passed the stone, but because their stone moved proximally. And we published a paper 15, 16 years ago about that as well, back in the days when we did more ureterotomies. But I'm still super thankful that this does show, as JD was just talking about, that the ones with distal ureters and they're not in crisis, that we should maybe give them a little bit more time than we have. And certainly the ones that are severely hyperkalemic and severely acidotic and, you know, B1s in excess of 200, we still move forward on those quickly, but I just appreciate the paper in general. Thanks.
Yes, go ahead, Dr. Dunn.
Yeah, no, thanks for that was a great review. I guess, you know, one of the things, or one of the limits also of the study is just it's a very biased population, because often the cats came in that were very azotemic, that refused an intervention, were euthanized by our emergency service. And so I'm hoping, you know, to try to get away from that as much as possible, because as you very eloquently said, you know, creatinine, there aren't predictors necessarily who's going to respond, who's not going to respond. And so I do think that the cats that were very sick, very hyperkalemic, oliguric, they were euthanized. And so, and that's not necessarily a bad thing if owners, you know, were financially strapped, but it is a very biased population because we collected those that kind of refused all the other treatments, but then had a little bit of money. So we tried to treat them medically. So I think there's that. One of the things that really kind of blew us away, I was not at all expecting that 50% of strictures would respond to medical management. And I wrongfully assumed that strictures were fibrotic tissue or fibrosis due to end-stage inflammation, or maybe a congenital lesion that became inflamed over time. And so I realized that what I thought were strictures were probably not at all strictures, because they were reversible, and how much of that was inflammation and spasm. And for me, it just raised more questions than it did answers. So what are these things that we're documenting? And I've sent a couple of them to histo, unfortunately, in cats that we euthanize, that we diagnose strictures, and it does come back as fibrosis with lymphocytic, plasmacytic infiltration, not much neutrophilic inflammation. But I don't know what these are. And so I think that for us, it raised more questions than answers. And I guess we still at our institution push for IR intervention, as I see in the polling that most people do too. And we were pleasantly surprised with the number that responded well, especially in the pyelonephrosis and in the stricture group. However, the time to response was many weeks. And I just feel that those are weeks that we're losing nephrons. So I don't know, I don't know if that's the right thing or not. And I guess hopefully in the future, it'd be nice to know what are the patients that are best treated by medical management, which are the ones that are best treated by subs or interventional, and which are the ones maybe that would most benefit from a surgical intervention. And so I hope that one day we're able to answer that question.
Yeah, looks like Dr. Foster had a comment.
Yeah, I think the spasm versus stricture is really interesting. And I don't know if Nav can comment on this, but when we did our pyelogram paper, we had a category of cats that we ended up calling a functional obstruction, that we would inject contrast and it wouldn't go anywhere. We wouldn't see a filling defect. We could essentially fill up the whole ureter, and it just didn't move, didn't go anywhere. And maybe we injected with enough force that we overcame a small obstruction that we just couldn't see. But it was not just one or two cats. I forget the exact number, but I don't know, Nav, if you remember, but there was a decent amount that weren't normal, that the contrast should zip down, it should be cleared quite quickly. And they didn't do that, but they also just didn't have your obvious obstructive qualifications that we would otherwise expect. And they certainly had a high clinical suspicion of obstruction, the whole reason that we did the pyelogram in the first place. So there's probably more to the cat ureter than what we give it credit for. We're talking about a tube that is, I think, nearly vestigial in terms of its diameter. So things that could cause an obstruction might get flushed out when we do a pyelogram because we're pushing with so much force. But we're probably still in our discovery phase of really understanding ureteral disease at this point.
Yeah, that's a
Yeah,
great
I just pulled the data quickly, and it looked like it was about 20% of cats had the functional obstruction, which was obviously more than we were anticipating, I think.
Yeah, and I'm kind of curious if you could give us more information on what the subset of cats was in this paper where the cause was unknown. Do you have any ideas, I guess, for what may have been going on with some of those cases, why it was so high in the euthanized cases? Is it just because we didn't have proper imaging, or the emergency service just wasn't able to give us a diagnosis before euthanasia?
Yeah, I'll answer. It's pretty much that. It's proper imaging. Either it was diagnosed really at the emergency service, so clearly the kidney was obstructed, but don't know by what, or yeah, the radiology report was insufficient.
Okay. That makes sense. I was just curious if there was some other weird etiologies I should be thinking about. But... Well, I mean, I think this was a great discussion. I personally feel like I've just learned so much again that even I didn't expect to see in my residency. Mainly the really chronic obstructions where, you know, we found them who knows how much later, and the dog or cat has just been living with it for probably months, if not years. And I still personally don't know how aggressive to be if they've already kind of lived and managed that problem on their own. And there's still that small internal part of me that feels like a bad nephrologist for not being more aggressive. But then on the other hand, they've far exceeded any supposed paper survival time this far, and they're doing okay. So yes, I feel like there's much to learn, especially with these more chronic cases and medical management. And I'm happy that we at least got some initial information that makes more sense and is more positive than the last one that we had in terms of giving owners some hope when they can't afford surgery.
Well, that was great, Metzere. Thank you so much for that presentation. The polls were great and so awesome to be able to get an idea of what everyone's doing and generated some fantastic discussion. So thank you so much for this presentation. Thank you to the authors that are on the call for the work and this research to help us further our understanding. Super appreciated. That is just really fantastic. And certainly invite everyone to join the next journal club. It will be on April 1st at 3 p.m. Eastern time. The article has not yet been chosen, but we will post that to the ACVNU's website. I'll certainly send it out on the ASVNU listserv as well too. Sherry, do you have a final closing statement there?
No, I was trying to clap. I'm sorry.
Amazing. Okay. With that, we'll call it to a close, and I hope everyone has a wonderful rest of your week, and we'll talk to you soon. Thanks, Metzere.
Thanks. Bye, everyone.
JD, are you still on?